There we go. Great. And then examine our own moral standing to ensure that our own work is ethical, worthwhile, and helpful to the voice student. So whether they're a singer, actor, or professional voice user. And hopefully the discussion that we have today is going to inform the way that we guide others. And as I mentioned in my opening, I don't think this is the work of one person, because it's quite enormous, actually. I think all of these ideas need to be created, developed, and discussed by everybody in the international multidisciplinary team. And so that is why we're here today. Now, in terms of contributing, we've got a lot to get through over the next couple of hours. The timeline is really tight, and that's mainly because I just wanted to squeeze in as much information as possible. So what I thought would be cool is if you have ideas or things that you want to add or ask throughout everybody's talks, please pop them in the chat. And then what Teresa, Emily, and I are going to do is we're just going to pull those questions out and keep a record of them. Now, if the speakers are able to see the chat as it's chattering away, and you are able to answer that within your presentation as we go, then that's wonderful. But if not, then that's fine. We'll come back to it in the discussion at the end. And so hopefully this is going to just allow everybody to have their say and have their voice as well. So our agenda today, I think, has been sent out to you all by Tracy, and I'm hoping, although I'm not sure because I've not seen anyone arrive yet, is there anybody here from the Mary Seacole Research Centre?
Yes, that would be me.
Hooray! Thank you so much. Brilliant, Nadia. Thank you so much for joining us.
No, thank you for having us.
Can I pass over to you and let you talk for a moment? Let me stop my share.
Yeah, of course. Hi, everybody. Thank you so much for inviting us. We had the pleasure of being at your previous conference as well, when you talked about all things music and singing and health and well-being and everything else. So it's nice to be part of this collective and see the wonderful work that's happening. So my name is Nadia Spiridenko. I'm an associate professor and reader in culture, identity, and mental health at DMU. I am based in psychology, but I'm also a deputy director for the Mary Seacole Research Centre. So who are we? What do we do? We're quite an interdisciplinary group of people. We are quite motivated by a kind of a common ethos and common perspective. We want to research diversity. We want to research inclusion, particularly with respect to culture and with impact on mental health, well-being, and resilience of communities in the UK and globally. So we are, as I said, interdisciplinary. We have members from all 4 faculties at DMU, so we're quite proud of that. We also have international reach and excellence in terms of our research and teaching. In terms of mental health, we look at migration, we look at inequalities of diverse ethnic and cultural communities. So that's our passion. We are very broad in our definition of diversity. We're not kind of limited to just cultural narratives. We're interested in mental health, learning, and physical disabilities. We're LGBTQI+ communities, spirituality, gender, looking at multi-agency working, looking at complex resolutions and interventions as well. So we're doing quite a bit of things, but it's all about inclusion in who we work with, who we research with, not on with. I'm very particular about that. And also looking at partnerships with creative individuals, with artists. We have a lot of research projects that involve participatory methods and creative methodologies, particularly looking at how creative arts can be used, giving people voice, quite literally through singing, as I'm sure you will be talking in terms of your work, but also more figuratively in terms of photography, film, theatre, and giving space, safe spaces and agency to communities that are sometimes not heard so frequently in research and in terms of their lived experiences. And we focus that through teaching and kind of rhetoric and diligence in bringing up the next generation of researchers, but also looking how this participation in creative art can be beneficial for mental health and beneficial for resilience. Because whatever community you go to, whatever place of the globe, there will be art, there will be singing, there will be creative practice. So I will not speak too long. I want to give you space for your wonderful, wonderful event. But I just wanted to give you a description of who we are. And if you do want to have those conversations, please join, drop me an email. I'll drop my email address into the chat. And we're very helpful, like welcoming. So yeah, to have conversations like this. So thank you for having us.
Amazing. Nadia, thank you so much for your introduction as well. So the Mary C. Cole Research Centre, as Nadia has just said, is based at DMU, which is where I'm doing my PhD, which is how we've been able to co-host with them today, which is excellent. So I'm going to do a really brief introduction. I'm not going to keep you long because I know that really you're here to hear from all of the experts. But essentially, I've started looking at ethical codes, and the intended learning objectives today will be to discuss the existing ethical codes for singing teachers, including safeguarding, learn how these boundaries are being pushed. So as I mentioned before, you know, like we're moving out of the traditional realm perhaps of a singing teacher and moving elsewhere, and then discovering how and why you can maintain good ethical standing in your own work, and then examine the impact of a multidisciplinary team as well. So let's start at the very beginning. I know you will all start singing in your head, so that's why I put that there. And so basically what I've done is I looked at AOTAS and I looked at NATS, and I've just pulled these off of the websites, and they're split into personal considerations, student considerations, and collegial considerations. And I thought this was quite a nice way to open because it's kind of like the really basic level of what we really want to do as teachers. So we want to share knowledge and be open-minded to colleagues' point of view and undertake CPD and training. I feel like we're here and we're all doing that. Being courteous and respectful, documented qualifications, honest advertisement promotion. You can read all this for yourself. And then down at the bottom there's self-care, so including voice, hearing, sight, hygiene, and general care as well. And moving into student considerations, we want to think about student welfare, data protection, GDPR, maintaining confidence and privacy. I know a lot of researchers will already be au fait with all of this because of the research you've been doing and the results and analysis that you've been keeping nice and private. And then giving honest feedback to students, including relating to their potential career and any industry advice. Creating relationships that foster excellence and learning, and avoiding discrimination. We also want to maintain appropriate boundaries in psychological, emotional, and physical contact, and allow students to choose another teacher if they want to. And then being respectful and impartial whilst keeping consideration of their ability, their learning styles, and their motivation. So I feel like so far we're doing pretty well, and it's pretty straightforward. Same for collegial considerations, so avoiding defamatory comments about others, working with others involved in the student development, and there will be more on that throughout this afternoon, and unbiased adjudication at auditions and competitions. So I think in a nutshell, this is our baseline, and we're just going to see how we're pushing these boundaries and where else we might need to explore. And at this point, what I'd like you guys to do is just have a quick think and think where these boundaries we might need to go a little bit further, like where, and just pop your ideas in the chat. So whether you've got a student maybe coming in who's had a really bad day and they're quite emotional, or if there's mental health concerns of your students, anything you can think of. There's plenty of you here, so just whatever you can think of, please scribble it down. Yeah, so counselling, yeah. I noticed we had a conversation yesterday, Emily, Rebecca and I, about ageing voices And so, when you're working with aging voices, they're a bit more vulnerable. I've actually got a whole slide. Keep writing, keep throwing things in. But basically, the next slide, I've put some ideas down on for you, which might just make you think. So there's vocal health, which is obviously what we're going to be talking about today. And this symposium genuinely could have gone quite big. There's also singing for health and well-being, dealing with emotional distress and mental health, musical performance anxiety or generalized anxiety, and then using other skills in a singing lesson setting, which I think Mel just picked up on, this idea of counseling versus counseling. So coaching and mentoring, working with vulnerable groups. Again, I'm just going to let you read through this yourself. And then I'm going to pass over momentarily to Yvonne, because we're going to move towards new ideas. So essentially, we're looking at improving education and educating ourselves on these matters. I myself have started sort of moving into looking at ethics related to coaching and medicine. And then obviously there's psychology and therapy as well. And then there's also the idea of, are we insured to do the things that we're doing in singing lessons, and what are the legal implications of doing this? And then finally, of course, multidisciplinary team. So without further ado, I'm going to pass you over to our first speaker today, who is Yvonne. Yvonne is an associate professor at the University of Illinois, teaching students majoring in music education and performance. She's presented at a variety of international concerts and enjoyed an 18-year career as a main stage soprano at the Met Opera, with nearly 200 onstage performances as a principal soloist. So as well as performing in many of the major opera houses and with orchestras across the United States. So Yvonne, thank you so much for coming. I'm going to pass over to you.
Well, thank you so much, everyone. It's such a pleasure to be here. I want to first extend deep gratitude and appreciation to the Voice Study Center. It's so nice to see faces that I see online all the time. This is very exciting for me. So I appreciate the opportunity to speak with you briefly about the ethical consideration of voice and music instructors to seek out regular hearing testing. Sorry, I'm going to make sure I start my timer so I don't go over. I should address a disclaimer above. My education is in vocal music performance, not in audiology nor acoustics. I teach voice and voice pedagogy, and the materials I share with you today are intended to raise awareness about how our musical environments can potentially expose us to sound levels that can diminish our hearing over time, and what that may mean as we assess sound. So a few years ago into teaching, I noticed changes in my ear after a few hours of lessons, and I kept developing what I describe as a whinge in my right ear. And I decided to do some reading on studies addressing teachers in the workplace and look into what might be causing this little whinge. And for voice instructors, the environmental factors can differ from students due to the duration of their noise exposure in a music classroom. Noise levels and the acoustic environment can contribute to diminished hearing, and because hearing loss is generally gradual over time, one is often unaware of what has been lost. So music studies have included either evaluating sound pressure levels of noise in the environment measured in decibels, and or administering audiometric hearing tests of musicians or music teachers. The following research papers caught my attention as I searched for information as they measured voice instructors. They reference National Institute for Occupational Safety and Health, or NIOSH for short, their hearing standards. And it uses the reference of a daily limit at 85 decibels for 8 hours. In the interest of time, I've listed these studies, but I'm only going to mention the last one. This study was conducted at the South Carolina Regional National Association of Teachers of Singing Conference. And of the 58 voice teachers who participated, 51.7% had some kind of measurable hearing loss. And when compared to the general population, these voice teachers reported greater hearing loss, suggesting this loss could be related to their occupations. In response to these studies, I organized a team for a pilot study of a day in the university voice instructor's workplace. This included my colleagues in the speech and hearing science department at my university and has been accepted to be published by the Journal of Voice. So we chose to integrate quantitative measurements of room acoustics, voice use, noise dosimetry, and hearing assessments to capture a more complete understanding of the occupational environment and to provide an objectively informed representation of voice teachers' working environment. This was a pilot study of only 8 participants, 5 professors, and 3 teaching assistants, ranging between the ages of 25 and 75. And pertinent to this talk, noise levels recorded by dosimetry placed at the instructor's shoulder were high. Regarding these measured levels, only 2 classrooms fell below the NIOSH recommended exposure limit of 85 decibels for 8 hours. The other instructors' safe time ranged between only 4 and 6 hours. Now, this is the entire recommended daily limit within just this teaching, these couple of teaching hours. So that doesn't include things throughout the rest of the day. Most surprising was that hearing assessments showed 7 of these 8 instructors had measurable hearing loss, and 3 of the participants were the teaching assistants under the age of 30. So in addressing ethical considerations, instructors of voice are expected to have sensitive and discriminating hearing, and in most cases are paid for this in addition to their experience. So in the studio or in adjudication environments, instructors regularly assess details of a performer's vocal delivery, such as tone quality, diction, and volume. Based on what they hear, a teacher's assessments directly affect the progression of a performer. In the studio, that may be the adjustment of articulators and phonation to produce a requested vowel, timbre, or volume asked for by the instructor. In the competitive environment, an instructor's perception and assessment can determine the performer's acceptance to a program, awarding of scholarships or prizes, or even gainful employment. A recent Journal of Singing article by Michael and Gilman compiles the results of intonation studies and suggests we are all not hearing the same thing when we listen to a singer. Yet voice instructors are expected to offer critical guidance to singers based on what they hear. Several factors influence what we hear, no question. But critical questions for voice instructors to consider are, what are we able to hear and what are we aware of what we cannot hear? So what changes to sound perception might occur with hearing loss, and therefore what is missing? What is our overall level of hearing and how often do we have it checked? What are the damaging factors in our work environment, and how best to preserve and prevent further hearing loss? A colleague of mine, Brian Munson, has written several papers on the perceptual significance of high-frequency energy in the human voice. The paper listed above is a literature review that you might find interesting. And while his research does not directly refer to how this might affect music perception, one can make associations with the 4 major points he names. So let me explain an audiometric chart down at the bottom right. A dip noted at 4,000 hertz, for example, here, means this person needs the tone to be raised by 40 decibels in order to be heard, as well as the frequencies tested around that. Anything over 20 decibels is considered sensory neural hearing loss, and in musicians, notches of hearing loss typically reflect noise-induced hearing loss, NIHL, which begins above 2,000 hertz and higher, this highlighted area that you see there. Based on Munson's research, hearing loss in music educators can affect them in a few important ways. Regarding diction, lowered hearing ability in this area may cause some vowels and consonants to seem muddy or mumbled. Some vowels with high second resonances, such as EA and A, may not sound as clear and could be perceived as dark. And likewise, consonants, particularly those plosives and fricatives, may be perceived as too similar, unclear, or non-existent. With regard to timbre, high-frequency hearing loss may be perceived by the listener as lacking brilliance and ring. And of course, this is the frequency zone of the singer's formant. In instrumentalists, high-frequency loss may make it difficult to distinguish between instruments. In the presence of background ambient noise, high-frequency hearing loss strongly impacts comprehension. In musical environments, this can include a soloist over musical accompaniment. Some researchers state that speech must be 30 decibels louder than the background noise for clarity. Therefore, hearing loss in this zone can complicate comprehension of a soloist with instrumental accompaniment. Lastly, research suggests that hearing loss in this area can also affect our understanding of where a sound is coming from, referred to as source localization, which could be important for conductors of singers and ensembles. So to conclude, a dip in an audiometric chart, such as what I showed, is a warning. It does not mean you cannot hear, but it's a warning to you that some loss has taken place, and you need to protect yourself to prevent further loss. Those notches that I demonstrated are common in hearing assessments of musicians and music teachers, if you read those research papers. So testing will make you aware of your hearing status and guide you towards preserving it. And as musical experts in diction and sound, all music instructors should have their hearing tested and know of any loss or any changes over time, since others depend upon our perception to assess the musical work they produce. I want to thank you so much for your time, and this concludes my presentation.
Amazing, Yvonne. Thank you so much for sharing. I think this is a really important point, and one we've got lots of questions coming in already. Those who have got questions, I wonder if you could save them until the discussion towards the end, as what I'd like to do for just for keeping time is I'd like to move on to our next speaker, which is Dr. Gerhard. So Julia is a speech pathologist and singer with a passion for interdisciplinary voice education and voice rehabilitation. Julia earned a doctorate in musical arts in vocal performance and an MA in speech language pathology from Temple University, and this then completed a Summer Vocology Institute through the National Centre for Voice and Speech in 2010. This training led to a clinical fellowship at the Children's Hospital of Philadelphia and a faculty appointment at the University of Miami. And Julia, you've recently relocated to Florida and become a mother as well, working as a speech pathologist. So you've really up busy.
All right, I'll take it from there.
Thank you.
Okay. So thank you, Kate, for organizing this. It is just such a joyful thing to me to be part of this and to talk about interdisciplinary voice care. I'm just really passionate about it, and I love this conversation among disciplines and internationally as well. So thank you, Kate, much appreciated. Okay, there we go. Okay, so thinking a little bit about ethics, I went to the medical ethics side of things. And the first two of the major 4 pillars of medical ethics are beneficence and non-maleficence. So that is going to be doing good and not causing harm. And I think that as voice teachers, as speech pathologists, as any part of the voice team, as human beings, I think we can all get on board with that. How can we do good? How can we not cause harm? So here, how can we best serve our voice communities? I think some of the most important things we can do are to create relationships among voice professionals. And here is something that I think is so important, that these relationships are well established. They're preventive rather than reactive. So we have this community already in place. And then when somebody, one of our students, a colleague, anybody has an issue that presents itself during voice lessons, during voice therapy, whatever, oh, how about this person? How about that person? Okay, we've got somebody here, and we're already trusting these people. We're already in communication. We know how each other work. There's open lines. That to me is one of the most helpful things that we can do for the voice community, in my opinion. Improving communication between professionals, especially between pedagogical and medical team members. And then better understanding the roles that everybody plays. And as Kate brought up, and Dr. Redmond as well, these ideas are changing as the roles are changing. And learning within the field of voice and continuing to educate ourselves, no matter which role that is, and on many different levels and in different areas of the field. Okay, and how can we harm our voice community? I think some of those things that, for instance, were listed on the NATS ethics page, basically just not doing those things can actually, I think, cause harm. Not having that network could mean a poor referral for someone, or not having a referral for someone, not being able to help someone. Divisive language, attitudes could lead to barriers there as well. Fear, not allowing ourselves to bring our best selves to the world, not allowing ourselves to share what we can, could actually hurt our voice community. So I think, I have their thoughts. That's something I think we need to think about together as a group. So how do we implement this doing good? If this is the goal, if this is our ethical obligation, if this is what we want to do, so we educate ourselves. I think reciprocal observations are very important. In my experience, that's been extremely helpful to me. And I know Lita Skiers is on this forum, and I want to let everyone know, I mean, I reached out to her for some guidance when I was in my coming up years, and I felt so welcomed by her generosity, by her willingness to explain things, kind of helping me along the way with some of my work. And I feel like there are a lot of people in this field, whether it be voice teachers or speech pathologists, doctors, other members of the voice team, who are more than happy to help and are just so willing to work with this process. Respecting each other's communication languages. So we communicate in different ways, just how voice teachers are brought up, just steeped in this language and culture, vocabulary. So are doctors, so are speech pathologists. And that's years and years within the culture, within the school, within the documentation style. And I think it's important to learn each other's languages. And yeah, that's a pun on the respect each other's love languages. It's respect each other's communication languages, because that's maybe part of the culture behind the different silos. And by learning them, we can bring them together. Documentation, I think sometimes that's not as much of an area of continuity in the voice teaching world as it is in the medical world. And that's something I think that could help bring unity and improve what we're doing. And then interdisciplinary and the network. So one study that I had done back in 2015, 2016 with colleagues, Dr. Lloyd, Dr. Zweem, Dr. Rosso, we wanted to know, how are voice teachers going about finding observations? Are they doing that? What is their experience with education in voice science? And we just we just didn't know. And so we sent out a survey, and as you can see here, the majority of the voice teachers who responded were master's or doctoral level teachers, had a lot of experience. So that's what we're looking at here in these results, faculty members. But the number of university level courses, there were a lot of people, the majority of voice teachers had, at least 2 to 3 courses in voice science. So that seems to be coming along pretty well. It seems like a lot of us are educating ourselves. And then when we looked at clinical observation hours, we can see that, so I don't know if you all can, there, that's a little better. So about 40% had 0 clinical observation hours, and we get to about 50% when we're looking at 4 hours and under of clinical observation hours. So in my opinion, I feel like that could be improved. I think that mutual, reciprocal observations can be very helpful. And with Zoom, now there's a lot more possibilities. I mean, the pandemic has changed our world. And in many ways, it's been so painful. And in some ways, there are these little silver linings that we can, I think, learn from and grow from. So clinical observation and lesson observation coming from a speech pathologist or a doctor, or a jazz teacher observing a classical teacher, all of these observations. I mean, this to me is very helpful and important. Live operating room experience. So this is also something I think about. About 90% of people have never done it. Now, I don't even know if it's important. I'm not sure. However, if somebody's going to be going in that you're working with and getting an operation, and I, as the teacher, have never entered a hospital, maybe that's possible, don't know what an operating room looks like, not quite sure what's going on, have never seen an operation, don't know what the tools are, haven't met a doctor, I just wonder, would it be helpful if even on a Zoom or watching videos, like that we can help people, guide people, this is what's going to happen, this is what, and maybe not saying like, I'm the medical expert telling you this, but like, hey, here's some information that might be helpful to you. Maybe I can answer some of your questions or let you know who could. And if we think about the field of sports, or a vocal athlete versus a sports athlete, orthopedic surgeons, physical therapists, laryngologists, voice therapists. But then when we get to trainers and coaches, if we think about what we expect a trainer to be doing and a voice coach or a voice teacher to be doing, and then when we think about their relation to the medical team, I think it's very common to think of a coach, going into the physical therapist, they're all on the same campus, they're all hired by the sports department or something like that. But in the vocal athlete, it seems to be more divided. So I know I'm coming up close on time, so I'm just going to go through these quickly because I think they're covered later. A voice teacher's roles and responsibility. The important ones I want to bring out here are appropriate and timely documentation and the relationship as part of a medical team, being able to make referrals, and having the accurate knowledge of medical terminology, documentation, and practices. So being able to read these notes, being able to send a patient with some paperwork, some documentation. This is where we're coming from, to your trusted friend and colleague, that you can send a voice student, maybe with a little packet with this is where they were able to perform when I first met them. Now they're having difficulties. Here are the exercises where there's been trouble, something like that. Speech pathologist and physician laryngologist, as the main two medical voice team members, would also have responsibilities, like maybe rounding with voice teachers. I had a doctor that rounded with the referring practitioners that she referred people to. Just, once a month, how's this person doing? How's that person doing? Work together. I think it was fantastic. Journal clubs, presenting for the community, attending performances in the community. So I think it goes both ways. Facilitating the other physician involvement. I think we can all grow from these extensions. So why is the communication important? It's more effective and efficient coordination of the medical treatment, improved access to services, and professionalism. So voice teachers can assume the professionalism of medical professionals. Doesn't mean we're doing the same jobs if I'm in voice teacher role or in the speech pathologist role, but I don't think it's overstepping the boundary to have that level of professionalism. And why is documentation important? I think this is tying in professionalism, having evidence-based, rationale-based teaching and being able to document that, progress tracking, increased consistency, assessment system, legal issues, and then also email knowledge. I've been in rooms where a doctor's looking at an email. Where's the point? Where's the point? I'm not, just kind of throwing it away. Whereas in medical situations, there's actually training on how to write an email, what to include, those types of things. So I think just kind of getting on the same page there. And I think I'm out of time. So I just want to mention here, bringing in the holistic and integrative partners as part of that team and using active outreach to build this network, really making it a priority and intentionally creating these friendships and collegial networks that will benefit us all and just make life more enjoyable, I think. So thank you very much. And I'll pass it on.
Beautiful. Thank you so much, Julia. I love the idea that this came, like you're coming from the medical point of view as well as the singing teacher point of view. You really have both sides of the coin there, which is really fascinating for me, because obviously I only have one half of that viewpoint myself. Okay, so without further ado, I'm going to move on to our next speaker. Hopefully you've all got a little time to breathe in between before I introduce Ginevra. Dr. Williams. After a successful career in opera, Ginevra turned her attention to investigating healthy and efficient vocal function. Ginevra was the first singing teacher to get a PhD in voice science in the UK, and this PhD looked at the impact of intensive singing training on the vocal health of boy choristers, and this same research won the 2010 BVA Van Lawrence Prize. Ginevra has also published the book Teaching Singing to Children and Young Adults, which I'm sure many of you have, and she now runs her own business, Evolving Voice, and has most recently set up Vocal Health Education. Ginevra works with both voice rehabilitation and career mentoring with professional singers, and is one of, I think, just 6 vocal rehabilitation coaches listed with BAPAM in the UK. Thank you, Ginevra. I'll pass over to you.
Hi, everybody. It's so good to see all these familiar faces. It's really lovely. Let's get this bit here. Okay, so the devil is there because I am playing devil's advocate to an extent here. Don't always take everything I say seriously, although I pretty well mean this very passionately, actually. What do we have at the moment, and what could we have if we did better? First of all, what is multidisciplinary? Now, this is a set of definitions. Multidisciplinary, people from different disciplines working together, each drawing on their disciplinary knowledge. So this is a team of expert practitioners. What do we have at the moment? We have this sort of structure with the doctor at the top. We have a speech therapist. We sometimes have a manual therapist. We sometimes have a psychotherapist, and sometimes there's a singing teacher. And all of these people have their own bias. The doctor is definitely biomedical. The speech therapist is biomedical with extra steps. The manual therapist biomechanical with extra steps. The psychotherapist is psychological with extra steps. Can the singing teacher be the one who is truly biopsychosocial? Have another look at this current voice clinic structure. It's hierarchical. We have the doctor, who may or may not perform surgery, then hands the singer on to the speech therapist, who will give the singer a certain number of sessions, who then hands the singer on to the manual therapist. Now, it's possible those two may happen at the same time or in parallel, but most of these treatments are in sequence, and the whole system can take a long time. The problem with the pass-the-parcel system is that the initial consultation is biomedical, it's not holistic, so the questions asked may actually not lead you down the right path to begin with. The process is unidirectional. I know everything and I'm telling you what you need. And it's hierarchical. It's not a truly joint decision-making process. So if we think about whether treatments can be in parallel, cross-referenced, keeping everything flowing, all right, this is the structure we have at the Voice Care Centre. And we have the initial assessment, the clinical lead, but then we have all of these other disciplines, other specialisms, all working together and the communication flowing backwards and forwards all the time. There's a team meeting every month. There's an online database where everything's logged. So the communication is much better. So let's extend our definition of multidisciplinary and take it further. Interdisciplinary and transdisciplinary. So transdisciplinary is creating a unity of intellectual frameworks beyond the disciplinary perspectives. What does that mean? It means that everybody has a practical working knowledge of everyone else's expertise. The team works together throughout the therapeutic journey. So, okay, if everyone has a practical working knowledge of everyone else's expertise, how do we maintain boundaries? This is the big question. And it's all in the contract. It's all in the contract between you and the client. So when somebody comes to me, I will state at the outset what my skills are, what I'm trained to do, what I'm qualified to do, what my insurance will cover, and then what the client can expect, and then we will agree. Do you or don't you want that? You agree how long it may take, so there's no open-ended arrangement that you may end up parting with a huge amount of money. If anything changes along the way, you need to renegotiate the contract. So that's the ethical side. So who might have the skills to lead the transdisciplinary team, to make that initial assessment and oversee the process? Just supposing we had Somebody with a knowledge of functional anatomy that had been examined, a knowledge of voice pathology, both academic and from observation, manual therapy training, counselling training, a special 12-week course accredited by the National Counselling Society, plus other relevant specialisms, so young voices, special needs, advanced, any of the above, and insurance, an insurance package that would cover all of these qualifications. That sounds pretty marvellous. But we can also have someone who has first-hand experience of what it is to be a professional voice user, a trained and experienced performer, somebody who knows and understands. So this is where we are now with our training at vocal health education with the voice rehabilitation specialist. And the VRS will be somebody with 10 years of high-level experience plus 2 further years of specialist training, and we're 6 months into that at the moment. How can we ensure that this new system of singing teacher specialist-led voice care is accountable and ethical? Contracting, supervision, insurance, regular independent EQA, external quality assurance checks from an outside source, and patient satisfaction. So what are your thoughts? Because before you say it can't be done, it's happening. That's it for now. There's a lot more I could say.
Brilliant. Thank you so much for sharing all of this, Ginevra. You've put together such a huge number of ideas that seem to answer a lot of questions. And I think you've really covered some of the ethics in there as well. So thank you so much for sharing. And again, we're going to whiz on. And next we have Pippa and Natalie, who are going to be speaking together. So a quick intro for each of them. Pippa's a senior lecturer and vocal health consultant for the musical theatre programme at Leeds Conservatoire. She's also a BAPAM registered vocal rehabilitation coach, so I feel very proud that we've got 2 of the 6 on with us today. Pippa is the vocal rehabilitation coach in a voice clinic for performers at the Freeman Hospital. She represents the spoken voice on the Education Working Party panel for the BVA and runs a busy private practice working with actors and singers, whilst also facilitating workshops and masterclasses on vocal health, hygiene and vocal technique throughout the UK. And then Natalie is a qualified speech and language therapist from Sheffield University, which was also my undergrad uni, and has over 18 years of experience working with voice and swallowing disorders. She's currently the clinical lead in voice at Newcastle upon Tyne NHS Foundation Trust and works as part of the ENT department also at the Freeman Hospital, assessing and managing complex voice, swallowing and upper airway disorders. Natalie is a guest lecturer at the University of Newcastle and is also a member of the Newcastle Voice Conference faculty. And without further ado, thank you both so much for joining us, and I'm going to hand over to you.
Hello.
Hello.
Hello. So, we'll just wait for Natalie to get her first slide going, and I'll start talking, I think, before that, because I want to thank Kate, Voice Study Centre, the SRC at De Montfort University for inviting us to speak. So we're Pippa and Natalie. Hopefully you can tell which is which from our cartoon characters, which are a little thinner than they are in real life. Anyway, today we're going to be talking about the ethical principles and considerations of having a vocal rehabilitation coach in a hospital voice clinic for the treatment of singers and performers with vocal injury. So as has just been said, we both work for Newcastle upon Tyne NHS Foundation Trust as part of the multidisciplinary voice clinic, and I am contracted as a volunteer.
And on this slide here, you can just see part of the mission statement that we have at Newcastle Hospitals. And you can see that it includes our aims to provide best quality care, but also ethically nurtured care.
Thank you. Natalie, I just don't think your slides are on full, you know what I mean? So you might want to press a little button there. It's all right, they're still not on. Is it going to go presentation full screen? Otherwise we're going to give it all away. There we are.
I know.
So I'm just going to talk about the vocal rehabilitation coach. So when we were preparing the presentation, we considered how having a vocal rehabilitation coach in the voice clinic could contribute to better quality of care for patients. And we also considered how we ensured that I, as a vocal rehabilitation coach working within the service, met the healthcare code of ethics. So firstly, we ensured that I had the competencies to fulfill this role. In the initial stages, this was the British Association for Performing Arts Medicine's competency framework, BAPAM. And as the slide suggests, I have a skill set for working with singers and performers, and that means I'm well placed to treat this cohort of patients. And on the whole, the training that's offered in the UK for the performing voice is not part of the SLT education programme, although of course they're fully competent with the speaking voice. Sometimes taking it to that heightened stage isn't looked at in the training. So therefore we have evidence that having a vocal rehabilitation coach in situ is an asset to the service. When I'm not in the voice clinic under Natalie's supervision, is it ethically appropriate for me, a VRC, to treat the injured voice in independent practice? So we've come to the conclusion that there are aspects of assessment that a VRC and a voice clinic healthcare practitioner both complete. But the problem with doing any healthcare work in independent practice is, as you can see from the slide, I do have limitations. With all my years of experience, I might tentatively diagnose a vocal injury outside of a medical model, but without an objective assessment for diagnosis, there is less of a guarantee that a treatment plan will be effective. In any profession, we've all got to start somewhere, but any limitations may increase the risk of inappropriate treatments in the independent practice world. And furthermore, there are no bands and grading criteria like there are in the healthcare profession in the hospital, which says where I lie as a voice coach, whether I am experienced in my role or whether I am a less experienced teacher. So what's brilliant is there are codes of conduct being recently developed, even on this slide now, and some that date back quite a few years. That's absolutely fantastic. But what we haven't got is a regulated body, and this could be seen as problematic. And it's just a question, but should we as individual practitioners be using medical terms such as rehabilitation or even health in our titles in private practice?
So moving on to healthcare, all aspects of healthcare in the UK are governed by a code of ethics. And medical ethics dates back to the early 1800s. We could even argue that it goes as far back as ancient Greece with your Hippocratic Oath. As a speech and language therapist working in the UK, my practice is governed by the Healthcare Professionals Council, which we call HCPC. HCPC is a statutory regulator, so it sets out and maintains standard for conduct as well as performance and ethics. And the objective of HCPC is actually to protect the public. So as an SLT, as a speech and language therapist in the UK, I have to be registered with HCPC in order to practice. And in order to be registered, I have to complete an approved programme of education. And in addition, I have to adhere to practice in line with the wider interests of my patient. So practices including confidentiality, record keeping, consent, mental capacity. I also have to maintain those professional boundaries with my patient. It's encouraged and advised that I work as part of a multidisciplinary team, and I have to keep within my scope of practice. As part of HCPC, I also have to maintain and develop my skills. I have to safeguard my patients, so I have to be very open and transparent when things go wrong. And I also have to be aware of my own personal ethics, so being very transparent if I have competing interests with my profession. My registration is updated every 2 years and my practice is audited. In addition to HCPC, I'm also registered with the Royal College of Speech and Language Therapists, and actually recently PIPA registered with this professional body as a speech and language therapy associate practitioner. So RCSLT provide me with insurance, but also they help to facilitate my continued professional development. They hold events, they hold webinars just to promote the profession, to promote my learning. And they also influence national policy drivers that include sort of aspects of the profession. But in addition, the college also produced guidance in terms of position papers. So the position paper I just wanted to sort of bring to your attention today was our position paper for voice. And it states here that speech and language therapy voice services should be commissioned as part of a multidisciplinary team in order to provide the most effective care. But the paper recognises that voice disorders do occur as standalone problems, but that it can also be secondary to other underlying conditions, such as head and neck cancer and such as neurological conditions. So therefore, it advises that before we undertake any voice therapy, that the patient is thoroughly assessed by an ENT specialist.
Sorry. So having considered that there is a healthcare code of ethics, let's reconsider why working with the injured voice outside of a voice clinic may carry risk. So as a singing teacher, I don't have access to medical assessment. I can take an assessment, but there is no medical assessment. We don't have easy access to other healthcare professions in general for comorbidities. We don't have a statutory code of practice, so there is no guarantee that all singing teachers are appropriately trained and are working within their scope of practice and are safeguarding clients and being transparent about their practice and even we hope they are, but they may not even be maintaining client confidentiality. And we know that in the UK, hopefully, most singing teachers working with the injured voice ensure that the patient has access to specialist voice clinic and liaises with voice clinic teams for appropriate treatment plans, but it's not a guarantee.
And so the main risk to the client with a vocal injury who hasn't accessed that objective assessment and objective treatment planning prior to commencing any therapy is that they're given the wrong treatment. And of course, the wrong treatment can be costly to the client, but it can also have implications for their health. The examples I have on this slide here are real life examples of patients who've received voice therapy, but without a confirmed medical diagnosis. So the first example is of a patient who was ultimately diagnosed with a vocal cord hemorrhage. In our service, we tend to recommend complete voice rest to allow the hemorrhage to recover. If we continue voicing on the hemorrhage, we are risking long-term vocal cord damage for that patient. My second example is of a patient who on case history, it was very indicative of a muscle tension voice disorder, but actually under laryngeal endoscopy, the patient was diagnosed with a vocal cord palsy. So firstly, we need to know what's the underlying cause of this palsy, but secondly, there are treatments in addition to voice therapy that can be more effective for a palsy, such as a vocal cord injection. And then lastly, a real life example was of a patient presenting to clinic with globus. After laryngeal endoscopy and after video fluoroscopy, so we also did an X-ray of the swallow, the patient was diagnosed with a post-cricoid cancer. And we know that a delay in diagnosis of a cancer can lead to disease progression, which thus results in poorer outcomes for the patient. So, Pippa and I feel it's definitely about that joint working. It's getting together and, utilising all of the skills of all members of the multidisciplinary team. And we absolutely feel that a vocal rehabilitation coach can contribute to best quality of care within a voice clinic, within a hospital setting, and that by working within that hospital setting, the patients are being ethically nurtured as well. This joint clinic enables the definitive diagnosis, it enables objective treatment planning, and it also gives us all wider access to the whole of the MDT, whether that's the doctor, a respiratory consultant, gastroenterology, psychology, or even easier access to the GP. As a volunteer in our hospital trust, Pippa is required to do mandatory training addressing the wider patient concerns, such as safeguarding, consent, confidentiality. Once we have that diagnosis and treatment plan from the specialist voice clinic, we feel that singing teachers or voice coaches are certainly best placed to treat singers and performers who have a vocal injury. That's it, Pippa.
So we just, our question at the end is, do we need a code of practice, our own code of practice?
I think you've made quite a compelling case that we probably do, actually. Really, really great. Thank you so much, both of you, for sharing a really thorough talk and ideas with us. Okay, so we've got two more. So Lida, we're moving on to Dr. Skiers. Lida's a soprano who's been featured in leading roles with several prestigious opera companies. She's performed as a regular concert soloist and has given world premiere performances of works written especially for her with chamber orchestras across the USA. Lida's a graduate of Indiana University with both a BA and MA degrees in vocal performance and has been teaching voice for over 30 years, serving on several university faculties in this time. She completed the Master of Science in Speech Language Pathology from Boston University, where she completed an internship in voice disorders and voice rehabilitation for the performing voice at the Massachusetts Eye and Ear Infirmary. She's currently a clinical singing voice specialist at the Duke Voice Care Center, where she provides rehabilitation therapy to singers, actors, and other vocal performers with voice injuries. Lida's also written a book, which I guess a lot of you will have as well, which is Singing Voice Rehabilitation, a Practical Approach to Vocal Health and Wellness, and is a frequent speaker on the topic of singing voice at national and international conferences. Welcome, Lida. I'm going to pass straight over to you. Thank you so much.
Thank you so much, Kate. And I'm mindful of your timeline here. Do you want me to try to compress a little bit to get back on your schedule, or and I will say the ubiquitous, you're on mute.
There we go. We said
we must have that moment.
No, I said that's fine. By all means, if it's a little bit quicker, that would be great. But
Awesome.
on my account, there's a little bit of wiggle room in there. Thank you.
I can do the same, Lida, so I'll catch up what you don't.
Excellent. Thank you. I will start my timer then. Gosh, I thank you so much, Kate, for organizing this. And I just feel so honored to be a part of this illustrious panel of experts and to have been invited to speak with you all today, and also, many illustrious professionals in the participants today. So thanks so much for organizing us on this important topic and for putting this together and for inviting me. I feel like I'm going to have some manual therapy on my neck because I just have been nodding so much for the last hour and a half at just these awesome presentations and just so much great wisdom that's come so far. So I've been asked to speak on this topic of a hybrid profession of kind of blending the singing teacher and the speech pathologist. I am in North Carolina in the United States, and I live in Raleigh, which is halfway between the Blue Ridge Mountains and the Atlantic Ocean. Kate has already gone over this, so I don't need to share that background with you. So we can dive right into some definitions here of singing voice habilitation versus rehabilitation, and what do we mean by those terms? So habilitation has been defined in at least one source as maintenance, building, and enhancing vocal skills and knowledge in a healthy performer, whereas rehabilitation can be defined as restoration of lost vocal function for a performer who has suffered a voice disorder or a voice injury. And I think it's important that we kind of keep our eye and our mind on that definition of rehabilitation as we go forward in this discussion. So in order to work with a singer who has a voice disorder, boy, there's a lot of knowledge that has to be kind of accumulated to achieve that really deep and broad knowledge about how the voice works, the anatomy and physiology, acoustics, vocal pedagogy, motor learning principles, and then on the clinical side, deep and broad knowledge of voice disorders, how to evaluate voices, how voice injuries impact vocal function, and therapy paradigms and practices for rehabilitation and principles of developing vocal exercises. So gosh, that's a lot. That's a lot. And it's really important to realize that most voice problems are almost always multifactorial. It is rarely one thing that is contributing. And so I'm going to echo what's been said already many times today. No single provider on the voice care team will have the full breadth of education, training, experience, and qualifications to address all of the factors that may be at play in the voice disorder thoroughly, effectively, and efficiently. It truly does take a team, as has already been stated today. So let's look into that team a little bit. So we have the laryngologist in the United States. That is an ENT doctor, ear, nose, and throat doctor, also called an otolaryngologist, who has gone beyond their residency in ENT to get additional training through a fellowship in voice disorders. Also on the team, we have the speech language pathologist or speech language therapist in England. And it's important that this person on the team really should have a very thorough background and training relative to voice and voice disorders. Even putting singing aside, speech pathology is a broad profession. And so the therapist on this clinical voice team really should have that deep training relative to voice disorders. But who should treat voice disorders in singers, which is this question we're discussing so much today? And this has presented a conundrum for many years, as several of you have stated and acknowledged. And that conundrum is, who is the best person to help the singer get back on track? The singing teacher is prepared to train singers, has knowledge and skill to build technique in healthy voices. The speech pathologist has the clinical and scientific background for voice assessment, understands the differential impact of voice disorders on how the voice works, and is conversant in therapeutic programs. So in other words, the singing teacher has expertise in building technique in healthy instruments, but may not have deep understanding of voice disorders, their differential impact on vocal quality and function, and how to treat. And I love my friend Ken Bozeman put in the chat a little while ago this idea of pedagogy-informed science as a important balance to what we already have heard lots of, which is science-informed pedagogy. So looking at the speech pathologist, they may have deep knowledge relative to voice disorders, voice science, and therapy paradigms, but they may not have that deep pedagogical knowledge. They may not necessarily have pedagogy informed into their scientific approach and how to apply that. So we kind of put this side by side a little bit more, these two professions. Speech pathologist has to have licensure in order to practice. And in the United States, we also, in most states, have to have certification from our professional organization. We are in the medical field, so aware of risk and liability and carry malpractice insurance. However, training for speech pathologists certainly does not encompass vocal pedagogy or performance. And being a singer isn't the same thing as knowing how to teach singing. So even a speech pathologist who maybe has a background and some experience in singing, that's not the same as having that pedagogy informed practice. And this isn't something that can just be picked up in a continuing ed course. In clinical fields, sometimes we do a weekend workshop in something, we get a certificate from that, we have some mentoring, and then we're able to go ahead and implement that into our practice. But this is not something that can just be picked up that way. So the singing teacher knows how to teach singing technique. Ideally should have a wide range of pedagogy expertise, but as Pippa and Natalie just discussed, there's no established credential or license for this. So it's difficult for the patient to make informed decisions about who they should go to for their care. And because they're typically not protected from malpractice, then that singing teacher is potentially liable for legal action. So looking at how this path to singing voice rehabilitation has gone in the United States, this term, singing voice specialist, was coined by Dr. Robert Sadeloff, even years before this specific citation I'm sharing with you today. And he describes that person as the singing voice specialist is a singing teacher with special training equipping him or her to practice in a medical environment with patients who have sustained vocal injury. Nearly all have professional performance experience as well as extra training in laryngeal anatomy and physiology of phonation, training in the rehabilitation of injured voices, and other special education. So this is very similar to what Pippa and Natalie were describing. And for many years, this really was the model in the United States for how this worked, with the singing teacher working with the medical team. I want to point out that many of the most important pioneers and trailblazers in singing voice rehabilitation followed this path, were singing teachers who worked in this clinical context. But it's important to realize that Dr. Sadeloff goes on in his definition here to say, a few of the best singing voice specialists are also certified licensed speech language pathologists. This combination is optimal, provided the speech language pathologist has sufficient experience and training, not only as a performing artist, but also as a teacher of singing, so they can inform their practice with pedagogy experience. So what he's suggesting here is kind of this middle ground, this crossover area of the singing teacher and the speech pathologist, the combined background really being kind of an ideal situation for rehabilitation of the singer. And so this term clinical singing voice specialist, that's not something that's widely in use. I'm proposing that here because that kind of distinguishes and makes it clear that this person is working in a clinical context, in a medical context. So more and more people are seeking this pathway. When I finished my speech pathology degree 17 years ago, it was very rare for someone to have this combined background of experienced singer and singing teacher and speech pathologist. But more and more people are following this pathway. And I think there are a number of factors that are contributing to this. One is that with that background, that person is unambiguously qualified to work in a clinical context and can bill insurance for voice therapy. But also in my conversations with a number of people who are considering this pathway or who have pursued this pathway, I think a big part of why people are willing to put in the work to get this dual training is just really having the satisfaction of knowing that you are prepared to do the work that you truly want to do in working with singers who have voice problems. So I recognize things are different in different places. I'm sharing with you this kind of model in the United States. Not every place has the same resources or the same pathway. But I think just kind of for some general practice ideas, we can think about on the singing teacher side, if you hear something, you need to get the team around the singer and Gosh, I just love what was just discussed about this sort of transdisciplinary and everybody really being there, and what Julia said about building those relationships and those networks early so that we can get that team around the singer. To me, it all comes back to the question of, on this team of vocal health, who's the most important person on that team? And to me, it's the singer. And so if we really keep that in our minds, I think that guides us in our ethical practices. Am I doing the best thing for the singer? So ethically ensuring that the singer's getting the care that they need. Now, at the very least, singing voice rehabilitation is in the realm of healthcare and ideally should take place under the supervision of licensed healthcare providers. I want to really point out here, though, this is a two-way street, and we've talked a lot about what the lane is for the singing teacher, but I also argued that the speech pathologist needs to be aware of their lane too, and their preparation and experience. So if the speech pathologist does not have that background in pedagogy, cannot inform their practice with that pedagogical knowledge, then it's important for them to figure out how they're going to collaborate with others and refer to others and bring others onto the team to ensure that we're addressing singing. Thank you so much.
Wow, Lida, thank you so much. Well, we've got some really exciting themes coming up here, and I think now we're getting to the point where some of the ideas are echoing things that have been said previously as well. So I think we're starting to see ideas and themes and some collaborative ideas really coming through, which leads us to our last but not least speaker, Melanie Tapson. Melanie's a professional singer, a singing voice specialist, and also a speech language pathologist who specializes in voice assessment and therapy for mainly professional voice users and performers. Melanie has a fine arts degree in jazz performance in both voice and drums, drum roll please, an education degree in senior level vocal, music and drama, and a Masters of Science in SLP, all focused on the voice. Mel has also enjoyed a long career as a performer and holds an adjunct lecturer position at the Faculty of Medicine at the University of Toronto, regularly giving workshops to voice users, voice teachers, and SLPs around the globe. And we are lucky to have you here today as well. So Melanie, let me hand over to you. Thank you so much.
Thank you so much. I just need you all to know I am doing the metaphorical run down the team, high-fiving all my colleagues as we go by, because I'm just going to give you the most gorgeous summary ever without ever having known that I was just slide by slide going to reiterate all the brilliance everyone has told you already today. So please enjoy this surprisingly on-point summary of today's brilliant event. So thank you so much first, Kate. I really appreciate it. I'm actually running two devices because I've been frantically making notes in between. So watch me try to do this successfully. There will be moments where we fail. It'll be fun. Live performance is always like that. So as Kate mentioned, I did my first degree in performance, and I largely did that because as a performer, everybody else was going off to school and I figured I better go to school and do something. But I was definitely going to perform. So it was just a good place to go and keep doing that. And then after that, I performed for a while, went back and did my degree in teaching voice. After that, went out, performed, ran into voice troubles myself, started looking for the answer, and decided I would go back to school to be an ENT, an ear, nose, and throat doctor, until I found out that would take me 8 more years. And I said, hell no, I don't have time for that. I need this answer yesterday. So then I found myself in school training to be a speech pathologist, looking at my own voice. And I was bemused to find that they didn't talk about voice very much, as many people have alluded here. So as a professional singer and voice teacher on one side, I have been the recipient of these services as the person that I am now, the clinical singing voice therapist, whatever we're calling this role. And I love that Lida mentioned that there's room or space for more clarity in the way we describe that. And one of the things that I find myself doing now, it's interesting that Julia talked so much about the idea that there are these gaps in our training clinically, because that's something that I found so frustrating when I was doing my own training. I had to get all the way through my degree in speech pathology and then go seek out the voice content I was looking for. So I've been trying to fill those gaps by doing mentorship programs. And one of the conversations that comes up all the time is, how do we as clinicians know when do we stay on an exercise if it's not working? When do we abandon it? And when do we abandon all, like maybe it's just not us, maybe this is the wrong fit. How do we know that? So I like to talk about this. If you are familiar with I thought a musical reference would be fun, the Kenny Rogers song that goes, you've got to know when to hold them, know when to fold them, sing it with me, know when to walk away and know when to run. And this is a great way to think about this framework. So when we think about knowing when to stay with an exercise, when do we hold our cards? We want to think about, what is the expected or anticipated outcome of this exercise? What is the therapeutic pathway we have been on? What are we hoping to achieve? What's our assessment told us is most likely to happen? And doing that really solid assessment clinically, which includes things that I believe Richard was mentioning in the comments, speaking to the voice teacher and getting recordings, for example, or going out and seeing the performer in their live environment. All of those things together give us a lot of information that helps us predict what is most likely to be helpful. So that's the first piece we need before we can decide whether we should stay with an exercise that might not be working yet, or if we should decide to change our tack. When do you decide when to fold those cards? It is a very frustrating moment to realize it's time to do something different than what you thought you had planned. But the first thing we can do is just move ever so slightly laterally. We don't flip the table and walk away. We go, okay, it's possible that this could still work. I just need to reevaluate my strategy. So can I, in the vein of best practice, think about what other prompts or exercises or explanations or maybe demonstrations might help me to get back onto this original plan that I had? So that's the next thing we might do. But then there comes a moment when we have to get up and maybe take a little breather and go for a walk. And I like to think of this metaphorically as going for a walk, or maybe even physically around the performer and thinking like, all right, holistically, what else is happening here? Maybe it's time to look at a different goal or a secondary thing. We'll come back to that first thing that I thought if it's necessary. Maybe we just need a more holistic approach overall. And while we take one at the outset, when we get into one sort of therapeutic exercise track, sometimes it becomes hard to remember that there are multifactorial elements that we might want to address. So we take a step back and maybe move to something else over here. So let's just get up and walk it off for a moment. But there does come a time when you have to run, like there does. There's a time when we go, it's not me, it's not you, it's something else. And the best thing we can do is call in someone else to help collaborate. Now we're collaborating the whole time, of course, but I mean, genuinely asking for a consult or sending them to another paraprofessional or bringing the team together and having a team conversation about what we need to do. Because here's the thing. You don't need to be a hero. As Lita mentioned so perfectly, this isn't about us as practitioners. This is about the singer. And I often tell the clients that I'm working with, as much as I am passionately driven to work with you, and I already like you, and I want you to do well, it's not about me, it's about you. So the best thing I can do is get you to the goals that you're looking for. And that might mean, because the knowledge I have is actually who is the best person to serve you. It may not be that I have the exercise you need. It might be that I have the network that you need, or that I have the perspective you've been looking for. And the truth is, I don't have X-ray vision either. I mean, yet we're working on that, but we don't have X-ray vision. So there are still team members who have information that we need in order to get the information we need to be successful clinicians. So what's interesting is, you'll remember Pippa was talking about the limitations of the voice teacher, but we also have the same thing as clinicians. I may now have many of the tools that I need to document and take a look at the data and discover what is it trying to tell me and what's the most likely outcome of the type of exercise I might choose. But the truth is that isn't foolproof. And as much as I have been working in voice diagnostically to some degree, either on my own or on singers I taught or coached, or as a clinician, I've been fooled. I've been fooled holding a scope in my hands, thinking we were going to see one thing and taking a picture of it. And I love seeing my colleagues nodding. We've all been there. That's not a sign of us not being good at what we do. It's a sign of the complexity of the human body and the singing voice. So we may have the tools clinically, but it isn't foolproof just because we have this supplemental medical training. And as Julia and Lita both pointed out, all of the knowledge of singing voice training was on me to find after I finished my degree in speech pathology. Never did we mention it. In fact, to be very honest with you, here amongst friends, I can disclose that for the most part, whenever I tried to mention it, I would be met with people rolling their eyes so far back in their head it was going to stick, because I was the only person who cared. Because my program wasn't specifically focused on that. In Canada, we don't have programs. We have so few programs, they don't specialize that way. So that's one of the challenges that we have too. So the most ethical thing we can do is to know what we don't know. And the way we know what we don't know is to keep learning, is to stay curious and stay as open as possible. And to know that whatever it is you know, it's probably also changing in the research behind you anyway, let's be real. And that experientially, there are always people who don't fit beautifully under that bell curve of research. And that's okay too. Just because it should work with someone doesn't mean they're wrong or you're wrong or anybody's bad, because it doesn't. It's because it's multifactorial. So we train our ears and we expand our repertoire of techniques and approaches as best we can. And we cross-train, like Julia was getting to, the idea that areas of counseling and areas of myofascial work or manual work, or many of these other areas that we can cross-train in as voice professionals, can be so helpful. To Ginevra's point, putting everybody in a space together and having all those, I loved the arrows that go back and forth between them. It's so helpful if we have a tiny bit of that knowledge in and of ourselves, so we know how to quickly initiate somebody going through to the next arrow. So those sorts of cross-training areas can be really helpful, but above all, practicing those skills, always practicing our skills. Now, I know I started by saying I wear all three of these hats as a performer, as a voice teacher, and as a speech pathologist, but the truth is, Lita said it perfectly, it takes a village. I don't have all the information, even though I wear all these hats, sometimes all literally at the same time. And it takes a team, it takes all of us having these conversations, because I still have my own unique perspective, and the knowledge that I have is valuable and helpful, certainly, but it's not everything. And here's a conundrum. Let's say you get to a point where you know, okay, it's time to bring somebody else in on the team, but you work in a rural area, for example, and the only clinician that you can refer to for a visualization of the larynx is a community ENT who's really an E when what you need is a T. Like, they're an ears guy and they do a great job with the E. And you're saying, can you just have a look at the T? Because you probably have more understanding of the throat than, you know, somebody who's not an EN and at least T. And they're like, yeah, great, but I really spend my whole day clearing out earwax. So that's not to say they don't have a helpful perspective, but again, without stroboscopy, sometimes we're missing information too. So just because we refer out to a colleague doesn't mean immediately we have all of the answers either. We have to keep, you know, that open perspective and open dialogue. And we have to really be thinking, what are we expecting to hear? What are we expecting to see? What will I do if I am wrong? What does that mean? I love that part of it, but it is a challenge because building those networks can be maybe not as easy as we'd like them to be. The truth is the pandemic's changed all that. I don't know if you can see behind me here, but I have a button where I just turn on a thing like Mission Impossible and I just swipe things around. Like, it's 2021, we're just swiping stuff in the air. It's a lie. But what we can do now is we can do like virtual consults and phone calls. So I can't even imagine pre-pandemic. And as you know, someone was alluding to earlier, it might have been Julia, the pandemic was not good. But one of the interesting things that came out of it is that the day before the pandemic, never would a laryngologist been able to, inside their facility, get on the phone and make an educated guess using their pre-screening information. And sometimes that is one of the helpful pieces, just to help you decide what path should we go down next, rather than waiting in line for months or weeks to get to that consult, to have a look, to still not get complete information, or whatever the case may be. So continuing to expand our network, as Ginevra so beautifully pointed out, the network just can't be big enough, in my humblest of opinions. There are so many people here that I see that I get a chance to talk to, but not as often as I'd like. But I love knowing you're out there. Like, I love when I see Ken, I love that Ken Bozeman's here today. I was excited. I was like, great. Like, we've got people talking about acoustics coming to talk about ethics too. And when I see all of you chiming in conversations that we have online, it makes me feel really heartened that we are connected to one another, even if it may not be in the same spaces. So you can continue to grow your networks, and this is a wonderful way to do it. My 6-year-old, I have two fabulously hilarious young girls, and my 6-year-old loves to sing the song from the My Little Pony movie, that goes, we got this together. And now whenever anybody's doing something and they're having a hard time, she goes, you got this. And the little one goes, do, 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 do. Because if you know the song, that's what happens next. And then they both go, we got this, do, 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 do. And then they both yell, we got this together. And the little one goes, yeah. Because she's so into it. So I encourage you to go listen to this ridiculously gorgeous song. It's hilarious. It's a wonderful anthem. And I just thought it was such a funny image that I chose too, because as Lita said, when you put the singer in the center like this poor sad bone, we're giving each other metaphorical hugs here too, but it takes a team. It really does. And we've got this together, but it really is a together approach. And this conversation about ethics couldn't be more important, couldn't be more timely, and couldn't be more necessary for us to have in an interdisciplinary conversation. So Kate, thank you for putting us all together. High five all of my friends and colleagues and every one of you who's here, who's contributing to this, who thinks this is important. And thank you for having me.
My goodness, thank you so much for coming, all of you. I'm kind of speechless, actually. I didn't expect I would be speechless at this point. I do have some stuff written down to say, but I feel like everybody else has said it. So I think probably the best thing I can do is pass over to everybody who is here listening. I have noted down 2 questions that came in earlier on, which I will just read out quickly, because I think they might get the conversation going. So Ginevra asked how to respond when we hear of inappropriate practice from colleagues. We know it's just the students' report of the comments, but what is our duty as professionals? And Rebecca seconded that. And then Richard asked, is there a place for voice recordings in the patient's documentation pack? And would the medical team want or be qualified to hear them? And I know Mel, you answered that within the chat already, but I'm going to just open up for you guys to shout out. Oh, Ken, there's a big one here. Anybody?
I'll chime in just briefly to thank you also. I think this is wonderful, and it's very timely for me because I'm currently very preoccupied with interdisciplinarity and what I experience as how we fall short of that. And in particular, I attend a variety of so-called interdisciplinary conferences. And I say so-called because what I find them to be is science conferences to which the rest of us are invited to attend and watch, or in our fumbling way attempt to do science when that's not our training. And the respect in the other direction in terms of the way the conferences are structured is often missing. Such that, for example, if you want to present a paper, it's usually vetted by a science committee to check its validity. And I realize it's a very difficult problem because there is a clear path and way to vet science papers by trained scientists, that they have a protocol that they can follow very carefully. Clinical practitioners, on the other hand, for example, I'm using that term a little bit loosely to also apply to voice teachers. I mean frontline people that are interacting with clients to habilitate and or rehabilitate, whichever their lane is. We are not allowed an untreated control group, for example. We have to treat the client in front of us. There are aspects, we use aspects of the scientific method. We come in with hypotheses, we come in with strategies. We should be science informed, absolutely. We should know what we're doing, but we don't have all of the necessary pieces of a high caliber scientific study. And so I find that the inclusion and respect is not as interdisciplinary as it might be for the benefit of all. we've got to find ways to legitimately assess the value of pedagogic presentations for it to be worth people's time, to see them at conferences. That's a tricky problem, but anyway, that's all I wanted to say about that. But I love this, the interdisciplinarity, the team approach. I think it's wonderful.
Thank you, Ken. I absolutely agree with you, and I think that's really come to light with three of our speakers today who have both of those points of view, because they are trained singing teachers, singers, professional singers, and also speech language pathologists or speech language therapists. So it's been so valuable to have both arguments. Anyway, Lida, you've raised your hand. I'm going to pass over to you.
This is just too important to not really underscore what Ken just said. And Ken is someone that I just admire and respect and have learned so much from anyway, but that's so critical. And I think Ginevra really got at that with this idea, this model where it's, kind of the physician at the top is very hierarchical in terms of the regard. And, that's kind of the last word is the physician, or maybe the really illustrious scientist. And it does often feel like there's not an equal regard for the incredible expertise and knowledge and ability on the singing teacher side, or really welcoming, just kind of changing that paradigm a little bit. And I feel like I just want to take that arrow picture, Ginevra, of yours with the circles, with all the arrows, and just really widely distribute that, because that's exactly what it is. There can't be this real top-down approach, and do the best to serve the people who we serve, whether they're singers or patients or research subjects, et cetera.
Thank you, Lida. I'm going to interject, Kristen, just before I ask you to speak, because I have a direct message with a question, so I'm assuming that whoever sent it wants to remain anonymous. And they've said, typically, I may hear something in a voice that concerns me, and I might try to teach some techniques which might improve the sound. But when it doesn't work, I suggest my student seeks medical help. And I have a range of contacts who I could suggest to my students. If the student is able to pay for this, then fine, but often they can't afford to pay. And the NHS currently puts voice problems as very low on the priority list. As long as someone can speak, communicate, and swallow, they do not even get a referral. So what do we do? Do we have any answers to that massive question?
I'm happy to jump in on this one if you want.
Yeah, please go ahead, Melanie.
This is such an ongoing problem. I do everything, and this is not always possible. I'm going to speak from personal experience. I do everything I can to make myself as available to voice teachers for questions. So at one point in my career, I worked in a voice studio alongside voice teachers, where I did voice therapy in a room that was down the hall, it was more private. And there was ways for people to maintain their confidentiality, but it meant between sessions, I was available to teachers for fielding questions when I happened to be available. It worked quite beautifully, and I'd love to find more ways to do things like that. I do a lot of continuing ed for studios as well, and try to be as available as I can for fielding these screening type of questions. Because I think even if we build wonderful teams, like you said, we often can't get the singer to the person, or like I was saying earlier, the wait list can be so long, or the doctor, like Ginevra said, who starts the conversation says, can't you just get a different job? And I always want to say, well, what job would I ever do where I never had to use my voice? And also, isn't it important enough that I just want to talk to my loved ones in a way that doesn't hurt, for example? So like the whole conversation today is so important, because all of the ethics of us doing the best work we can exists in a void if people can't access any of those services. So I think the best we can do is continue to, where we can, show up when those of us who have bandwidth in a given moment have the availability to share things and make things like you've done here available for free, so we can help each other to train, so we can reach out to teachers and give them the best knowledge we can. I think building networks goes beyond the moment where we're working specifically on a one-to-one client. And I'd love to keep having more conversations about how we can do that inside the scope of each of our own practices, and ethically, and not giving people too much specific information when we're not seeing a specific client, but to help guide them better would be so wonderful.
Thank you. Yeah, very nicely put. Kristen, over to you.
Yes, thank you all so much for this wonderful workshop, seminar, conglomerate of fantastic ideas. I wanted to jump in with this idea that's propagating of the elitism that we often have when it comes to conferences and research, and that is so real, and it's really rooted in colonial constructs. And so I think what we're talking about here in this, multidisciplinary idea is a form of decolonialization. So we're breaking down these ideas of that your research is only valid if you have this certain academic status or follow these certain procedures. There has to be more of a conversation and a dialogue. And we're seeing a lot more of this decolonialization conversation happening within academia. I'm in a PhD program doing voice science, singing voice science right now, but I come from a singing performance background. And this is something I'm fighting constantly, this battle of you're not superior just because X, Y, and Z. And how do we break down those structures and find validity in experiential circumstances? And it's a battle, but I'm really optimistic because I see so many of my colleagues fighting the same fight and trying to make sure that there is an equilibrium and that we're not in this sort of ranked society or class-driven structure within academia, that we're taking out some of this elitism across the board to have more cross-pollination. So that's all to say. I think this is a fantastic step moving in that direction to hopefully have a future where we're not inserting all of this bias in the process, but we're actually listening in relation to rather than as a representation of. So we're not listening because someone has power or we deem them to be better, but we're listening in relation all together. But anyways, that's just my thoughts on what's been said, and I'm really appreciative for this.
Thank you so much for sharing, Kristen. I really appreciate it. And again, some more wonderful ideas coming through. Julia, I think you raised your hand next.
Thank you. I wanted to thank Ginevra for her talk. And one thing that I had to add to that was when I was doing that program for training during my fellowship, along with a clinical psychologist, it was just to kind of introduce us as therapists to the world of grief. And we were working at a children's hospital, so how to talk with parents who might be experiencing grief. And she asked me to bring 2 examples of problems I was having because of grief to my session with her. And I couldn't find any. I was seeing all these patients throughout the whole hospital. I couldn't find any. So I came to her, I said, I don't have any with grief, but I have 2 really challenging cases. And I told them to her, and she said, guess what? And I said, what? She said, grief and grief. And I went, oh my gosh. And she explained to me, just how these were grief related reactions, and why my interaction with the parent was being impacted by this. And I'm telling you, I had no idea. And this was already when I had been through both of my training programs. I'm at the fellowship. And so I think there can be so much to be said for that. And it really did blow my mind. Like I was completely shocked. So it's just so important. And maybe it was taught, but not with the clinical. I somehow hadn't gotten it before that clinically based investigation of it. So thank you. Thank you.
And then Ginevra, do you want to take over? I feel like you're the perfect person to speak.
Thanks, Julia. I think so much about this is the holistic thinking, knowing that everything relates to everything else, and everything feeds everything else in the mind and the emotion and the culture we're in, as well as what we're doing technically and all that. So it's all to do with asking the right questions. And I don't think you need to be a counsellor or a psychotherapist to ask the right questions. You have to know what questions not to ask. but you can ask informed questions. So, for example, I've just heard very recently in presentations by doctors, yes, I'm holistic because I look at their feet as well as their larynx. That's still biomedical. Yes, I'm holistic because I tell them that they're going to be affected by other things. And I think, why don't you ask them instead of telling them? And I've just got some questions here, which was in the cuts from my talk, because of course we all had to cut loads of stuff out to fit into 10 minutes. These sort of questions: what's been happening? Why are you here? What would you like to be the outcome? Why now? What else is happening now? What does that feel like? How is the rest of your health, sleep, exercise? What is your support dependency network? Has this ever happened before? What else was happening then? How did you feel at that time? What else helps you? Those sort of questions. You don't need to be a psychotherapist. You just need to be a decent human. And any decent human can ask those questions, and it will give you so much information about what is going on with that person and why these things happened at these times and what the background was for them.
Fab, thank you. Okay, Jennifer.
Hi, well, thank you so much for everything today. It's been so fascinating. I've loved the conversation. So many good points. It's been great. I am on both sides, so I'm a singer teacher and a psychotherapist, music therapist. And my like thought process at the moment, as on kind of both sides, I do find it beneficial to have my psychotherapy training even as a singing teacher, and it's informed my practice, and I've become a different singing teacher since being qualified as a psychotherapist, just because I can trauma informed, mental health informed, just well aware of like attachment theory and things like that, where I'm not bringing them in, but if I'm aware of those things, to say if someone says, yeah, I've had X amount, this trauma, I'm just aware that actually these behaviors might present, and just to be aware, not to help or be a therapist in that situation, but to be aware, and as Jennifer says, just be able to be a human, to appreciate those situations that the student is bringing me. My only concern is when a singing teacher, so in some of my settings, I am literally it's just me. So, or it's me and a load of other teachers. So say it's in a school, for example, you're not necessarily going to get an MDT. You're just not. So, and obviously you might know a speech therapist or an ENT to signpost to. We might be able to kind of write a letter to a GP to say, look, and kind of to push that referral through if the student's really struggling with the voice. But my concern is if, say, the person is going through trauma or going through something really difficult and they're on a waiting list because the NHS or whoever else, the therapy is not getting there, or they're being offered CBD when actually do not need CBD, they need like psychodynamic therapy. If they need something further than CBD and it's not coming, and they're coming to you then instead and saying this, and give it, like, what do you do then? So if you are counsellor trained, even still ethically, you're not supposed to be given help, because health wise HCPC would just, if they found that you had given music therapy or psychotherapy or physical therapy to someone in your singing lessons, HCPC would be like, you're not a physiotherapist, so why are you helping them with the ankle or with the elbow, or with the voice, for example? You're not that. So HCPC would put a stop to that if they found that kind of malpractice, is to say. And that's why insurance wouldn't cover you to do those skills. So I'm wondering, like, for those teachers who are by themselves, how do we train them and also warn them of those barriers to their profession? I suppose that's my own overall question, I suppose.
I love that question, Jennifer. Does anybody have an answer for that? Or is this something that we need to work towards to answer together, perhaps? Total silence. I'm going to go with working together for that. So a really good question there, Jennifer. I think you've got everyone stumped. And Kenneth, you have your hand up.
Sure, just three brief responses. This is wonderful. To Julia, this isn't an ideal metaphor, but I'll use it anyway. So the role of the clinician, the fact that you had to learn those things at the clinical level because you couldn't learn them in the classroom. I often use this metaphor: nurses know things doctors don't know. And, you know, that's not the perfect metaphor, but the idea is that the people that are doing a lot of contact with that you learn things that can't be learned anywhere else. And there's value in that learning, whether or not it's been submitted to, double-blind scientific methodology. Okay, so that's one. The second comment is, and yes, we don't want a hierarchical structure. We want a conversation, but there is such a thing as an expert. There is such a thing, and that isn't hierarchical. That's just rational. You know, a person over the lifetime develops a certain facility. There are better, or there are people that have better track records, I should say, as pedagogues or as doctors or whatever the discipline is. And while we want to be able to hear and stay open to all voices, we do need to take advantage of expertise gained so that we can grow and build as we go forward. So there's somehow, even though we don't want hierarchy exactly, we do need to still have a way of assessing where is the expertise. And then the third one is just a sort of amusing. There's such an interesting gender imbalance in this meeting today, and I find that very interesting. And I wonder what the heck is going on there. But anyway, I'm glad to be here and learning from you all. Thank you.
Thank you very much, Ken. And Aliki, over to you.
Hi, just a brief, potentially irrelevant thought for you, Ginevra. Hi, in relation to your question about boundaries and how do we determine the boundaries and how do we know the boundaries. So I come from a weird background with a lot of training and a lot of work experience in film before I switched to singing. And in film, the boundaries are really well defined and incredibly clear. Two things that are really nice about film. Number one, you have the first AD, who is literally the person who oversees all the arrows and makes sure that all the arrows are constantly ongoing and are happening, and that there's not a one-way conversation. So there's actually a role and a job that does that in film. Second thought is that if someone wonders whose job it is to do something or what the boundary is, the way that it was generally framed for us always in film was that if you're asking that question, you don't know that person's job well enough. You don't have enough knowledge about that other job and the specialization. So find out more about the job. Hi.
Over to you, Ginevra.
It was a statement more than a question, wasn't it?
Was it? Okay. I thought it was a statement for you.
It was a statement about really just reinforcing the fact that we do need an in-depth knowledge of everybody's job as much as we can. I mean, I can't have an in-depth knowledge of what it's like to be a surgeon. And I'm not, I go to lectures on and watch videos of surgery, but it doesn't mean I'm just going to get someone on the kitchen table and get the knives out, But I can talk to surgeons and I can go to clinic and I can even go to theatre and watch things happen and just get a bit of a sense of what they do, which helps me and helps them.
Fantastic. Thank you very much. So I feel like we've fulfilled our time together really beautifully, and we've still got people here at the end and people eager to talk. Are there any more questions before I just do a final roundup? Okay, great. Well, I just want to say a really huge thank you to everybody who has joined us today. So to the Mary Seacole Research Centre, Nadia, thanks for joining us and introducing. Yvonne, Pippa, Natalie, Ginevra, Melanie, Julia, Lida. I just think it has been such an informative and much needed symposium, and I can't thank all of you enough for joining us and sharing your areas of expertise. I think the idea of it's all about the singer, really, and we're doing all of this for the singer. The idea of reciprocal observation and cross-training is fantastic, and we're looking at patient, and I know I think Lida, you said patient satisfaction, but I think this idea of singer satisfaction as well kind of comes into that, versus like the HCPC registration and the value of protecting the public. So making sure that we really are thinking about where we have to be boundaried and thinking about our own morals, as well as how we can have this together. So thanks, Mel, for the song. I am going to go and Google that afterwards and then know what we don't know. So I want to say a really huge thank you to all of you for coming along today. I'm absolutely blown away with all of the masses of information. And I also would like to say, somebody said earlier on maybe about doing something else. And I already have planned, no date yet, but early next year, I'm hoping to do a follow-up for this event. So I think we're all in agreement that there's been questions presented today that we've not been able to answer together. And so what I'm going to do is I'm going to put another call for papers out, and we're going to do a follow-up. So how can we find some solutions to the questions posed today? And again, it's this idea of bringing the team together, having these collaborative conversations, and offering free events so that everybody can attend and everybody can be a part of that conversation. And with that, I'm going to say thank you to you all for attending, and goodbye.
Thank you, Kate. Thanks, everybody.
Thank you.
Bye-bye.
Thank you so much. That was amazing.
Thank you. Bye-bye.
Thank you so much.